And so this question is for Dr. Shields. The audience is asking, what would be your go-to regimen for limited stage small cell lung cancer, and what is your surveillance practice?
So, great question. I think that this is an evolving field. And so, particularly focusing here, I would say, on patients who have stage 2 or stage 3 small cell for limited stage, so meaning it's involving the lymph nodes, and surgery was not an option. So for my practice, typically is meeting patients. I do typically refer my patients early to palliative care. I think having the most support, having dietitians, having early palliative care, really jumping on board with these patients and supporting them early, because this is an intense regimen and we want to make sure that they have every area of support that they need. And so typically that is meeting with the patient, discussing platinum-based chemotherapy. Typically, my preference is usually carboplatin. But that is a patient and physician discussion to discuss whether that's cisplatin or carboplatin. Cisplatin does come with additional toxicities and more chair time with infusions for fluids and such. And so meeting with the patient, discussing those side effects, and then having a patient referred to a radiation oncologist to receive radiation. Now, the schedule for radiation could be once daily or twice daily. If it's twice daily, it's typically very consolidated, and then most patients may have a very hard time getting radiation in the morning and also at night for such a intense schedule of over usually 3 weeks. Typically, I give 4 rounds of chemotherapy along with the typical radiation, which is given typically over 2 cycles. So you have an overlap of the chemotherapy in one area and the radiation given concurrently. We know that patients who receive at the same time and have the most overlap of those do the best. And if we are moving those areas to a sequential, that can impact negatively patients' outcomes. And so as we are getting through each round, I see patients with each round of chemotherapy to check in, see how they're doing. We do see that blood counts do drop with this regimen. And so really checking in, seeing how they're managing, if there's anything else we can support them. And as we're getting closer to the end of the regimen, we typically start discussing prophylactic cranial radiation, or PCI, which is whole brain radiation for prophylactic or prevention of possible brain mets. I think having them meet with a radiation oncologist, getting as much information. We talk about the Maverick study, which is a SWOG study that'll read out in 2027, looking at the role of whole brain radiation, or PCI, versus active observation with MRIs every 3 months. So we talk about the caveats, and usually it's a patient and provider discussion. We weigh the risk and benefits. I have them meet with a radiation oncologist and to decide whether they'll pursue that or not. And then we do scans every 3 months, at least for the first 2 years. And then we start to extend out based on our NCCN, or national guidelines for cancer management, because the risk of small cell coming back is the most in the first 2 years from diagnosis. So we want to very closely follow the patient and make sure that there's any changes, we catch it early and intervene early. So hopefully that helps.
I saw a lot of head nodding, so I think there's a lot of consistency across practices. And so this question is for Dr. Roto. And so the question is, if someone has started osimertinib by itself, or Tagrisso by itself, and then they added the chemotherapy 6 months in, do we believe that the benefits extend to that population as similar to someone who starts with a combination up front?
Yeah,
I suspect there's nuance here, but
yes, definitely. And I think this is an interesting question, because I get it from patients and caregivers, but also from other physicians. I think this comes up a lot. Can you say, start with the pills alone and then see if you like the response you get, and then add chemo if you feel like you're not getting as much response as you wish you could have? And I have to say that's not a strategy that I recommend. And the reason is, when you look at where the benefit comes in, these upfront combination therapies, it's a little bit less about that initial response and more about the durability of that response. So I think when we start osimertinib alone, a lot of our patients have a really nice decrease in disease, but that doesn't always correlate with the durability of response. And we carry both about how many people respond, but how long does that response last? So we don't know if we wait and let the cells kind of get into that kind of persister state and then add chemo, are we getting the same benefit as when we add it right from the beginning, or if we do one of the other combinations like amivantamab, lazertinib, right from the beginning? So my advice is really to, if someone's just been on for a few weeks and we're seeing them for a second opinion, having a conversation, that's a very different story. Or if someone was really quite sick from symptoms of their disease and they do a few weeks of pills and they're feeling a lot better and now suddenly a good candidate for things like chemotherapy, and it's a whole different story as well. But I'm usually trying to embark from the beginning or close to the beginning as possible with either upfront monotherapy or combination. So I suspect there is practice variation here, to be fair, but that's my own personal strategy and how I counsel people about it.
And there's trials in this space as well, trying to use ctDNA dynamics, et cetera, to inform when to add it. So Dr. Shields, a point of clarification on your last response to the therapeutic, I guess the regimens that you recommend for limit stage.
Obviously, I must need more coffee. So just one more additional thing, I was focused more on PCI and scans, but, standard of care is durvalumab monthly for 2 years to 2 years after. So that is an absolute must to discuss with your doctor. And I don't want to omit that. And so I wanted to update that my recommendations about after you have your scans for your 4 cycles, you've completed your chemo rads, and everything looks great. Getting immunotherapy with durvalumab monthly is a absolute standard of care. So just to clarify.
Fair enough. I think a very, very important clarification.